My dear medical fraternities and my friends and colleagues, I am posting this video today for the second COVID 19 management for the medical fraternities. Usually, the second wave is entirely different from this first wave because, first of all, number one, it is a mutant virus and the rate of infectivity, otherwise called the secondary attack rate, is very high because this mutant virus is very potent and the infectivity rate was very high all over India. It is starting from this 20% to 30, 35, 40%. So there is a problem in getting beds, getting oxygen, getting manpower, getting drugs. All are a problem for the government and administration. And the age of attack that ranges from pediatrics to geriatrics, definitely. And almost pediatric patients to geriatric patients are admitting in the COVID positive wards. And the point of interest is most of the patients attacked by this COVID 19, the second wave, this mutant virus, is targeting the middle-aged population, 30 to 50 years. And the death rate is enormously high in comparison to first wave, and most of the death occurs between this middle-aged population of 30 to 50 years. And with this small, our Theni district, comparatively the death rate is very high. So second wave is definitely different from this first wave. And now coming to the subject proper, usually the COVID symptoms usually are the fever, sore throat, headache, nasal stuffiness, nasal congestion, cough, and vomiting, diarrhea, severe body pain, myalgia. These are all the routine symptoms, and these symptoms occur after the incubation period, and then within a short of 3 to 4 days all the symptoms usually coming down, and the patient totally relieved of most of the patients relieved of the COVID 19 illness, and they feel that they are all okay and they are totally free from the illness. But actually, the original, it will happens to more than 80% of the population. Yes, it is still correct. Within 5 days, they will all become all right of the more than 80% of the COVID 19 affected population. But the 20% of the population will have still in the state of risk, and this is the time the viral replication is enormous, and this is the first, it is the time to intervene the patient with remdesivir injection, which is a RNA polymerase inhibitor, and definitely it will helps in inhibiting the multiplication of virus inside our body. And if the symptoms persist even after 5 days, or the patient is free of all the symptoms which have occurred from the day 1 and all will disappear at day 5, and then onset of new symptoms or persistence of symptoms after 5 days, 7 days, we should be very careful because these are the patients have come into the stage of dangerous cough and go into the next stage of the illness. So this is the stage where we can have this cytokine shower, and within 7 to 9 days almost all the virus is free from our body, and the next stage of cytokine shower will take over and do all sort of problems and lead on to death of the patients. And the persistence of symptoms or onset of new symptoms to the patient is most important point of view. All the medical fraternities should be taken care of, because the problem with these symptoms and signs of this after 7 days of illness is to be considered very seriously, and the patient will go in for dangerous cough and enter into the phase of cytokine shower, and the cytokines are released, and the cytokines make the patient a hyperinflammatory state. Inflammation is something different from hyperinflammation, and the major difference between this is the coagulation system is activated, coagulation cascade is activated, and the cytokines are enormously released from our immune system into the bloodstream, doing all sorts of nonsense, problems to the body. And these cytokines causing this hyperinflammation, producing activation of the coagulation cascade system, producing endothelial injury, lead on to microemboli formation, especially in the pulmonary capillaries. And the patient will go in for viral pneumonia with the inflammation and hyperinflammation, and this state will come. They say that is a pulmonary endotheliopathy. Pulmonary microemboli are formed, lead on to V by Q, ventilation perfusion mismatch in our pulmonary system, lead on to desaturation, fall in oxygen saturation. And in this stage, our remdesivir has no role at all, and the only treatment for this cytokine shower or lead on to cytokine surge and lead on to cytokine storm and finally to death of the patient. So in a state of cytokine shower where the symptoms appears, and we can confirm it by taking this investigations of complete blood count, where this WC are very high and lymphocytes are very low, and HCRP is increased, C-reactive proteins are increased, and D-dimers are increased. And this D-dimer increase will definitely confirm that the patient is in a state of hyperinflammation. So our treatment aspect is entirely changed, and our treatment is steroids and low molecular weight heparins or fractionated heparins, and oxygen therapy because of the fall in saturation, because of the viral pneumonia, lead on to ventilation perfusion mismatch. So in this stage, suppose the patient come to you with the cytokine shower stage to the clinician. Clinician should have the knowledge, clear-cut knowledge regarding when the first symptom occurs, and the symptom occurs, what is the first symptom of your illness? That is the most important thing. The patient have cough or minimal sore throat 7 days back, now it come to you to your office room with the complaints of high fever and myalgia only for 2 days, and we miss this cytokine shower, and we just give antibiotics and paracetamol and let the patient to go home, and the patient come to you with tachypnea, dyspnea, desaturation, with respiratory failure in a very bad shape. And that is the thing I want to emphasize you. You calculate the symptoms. When is the first symptom occurs? If it is more than 5 days, he is having this symptom or new onset of symptom or persistence of the initial symptoms continuously, you should be very careful regarding this. Never miss this cytokine shower. That is the most important thing. And the patient has entered into the stage of dangerous curve. That is the thing our medical faculties to be aware of it. And you have to start the only drug that will arrest the actions of cytokines or steroids. And for this hyperinflammation, activation of the coagulation system, lead on to pulmonary microemboli, you have to give these anticoagulants by means of low molecular weight heparins or fractionated heparins. And regarding this desaturation, fall in SpO2, that is measured by simply by our pulse oximeter, that shows if it is more than 95, there is no problem at all. The patient doesn't need any oxygen. And patient in a state of SpO2, the oxygen saturation is 90 to 95, is in a mild stage of lung involvement, and the lung involvement would be less than 20%, 20 to 30%. And these patients need oxygen therapy definitely by using this simple oxygen mask. And never waste this oxygen, it is very precious, we cannot get back it very easily. By using this very simple oxygen mask, you can start with 2 liter and gradually increase 3 liter, 4 liter, 5 liter and 6 liter maximum by using this simple oxygen face mask. And if the saturation is maintained more than 95, 94 to 95, and it is okay, you can stop with this level. And if even with this face mask, the patient can not able to maintain the saturation. If it is less than 92, you can switch over to next device called NRBM, non-rebreathing mask, which has the very high flow rate. Then simple mask of 10, start with 10 liters and maximum to 15 liters. And with this instrument, we can give FiO2, that is fractional inspired oxygen concentration delivered to the patient. That is more than 90%. But using this simple face mask, you cannot increase your FiO2, fractional inspired oxygen concentration delivered to the patient is maximum of 40%, 0.4. But in this NRBM mask, that otherwise called high flow oxygen mask or non-rebreathing face mask, you can give the FiO2, that is fractional inspired oxygen concentration of 90% to 95%. By using this flow rate of 10 liters, starting with 10 liters and maximum to 15 liters. Even with this NRBM mask, we cannot able to maintain the oxygen saturation. You can switch over to next mode of oxygen therapy device, that is called HFNO, but it is very luxury for oxygen. It need enormously consumes oxygen of 60 liter per minute, and in this situation with this oxygen deficits, and it is not ideal to use this machine. Nowadays we can switch over to CPAP. By using this CPAP with a brain circuit attached with a flow rate of 10 to 15 liters with a tight fitting face mask, with the brain circuit is attached with a tight fitting face mask, that is called NIV mask, non-invasive mask, face mask. The saturation is drastically improved by this 10 to 15 liters of oxygen, the same as utilized in NRBM mask. And in our ICU, we are having this more than 10 to 15 patients are getting this CPAP mask with brain circuit. We are having this saturation of more than 90%. We can able to maintain. The patient come with a saturation of 75 and below. That is why I am mentioning in a very detailed way. We can, very simple thing, get a 500 rupees of this brain circuit and one NIV mask of 2000 rupees, and 2500 rupees. If a circuit is over, nothing else, you can attach directly to the oxygen resource and no ventilators is needed, and you can continue this device as a CPAP, and saturation is well maintained in our ICU. And still now we cannot able to maintain with this CPAP mask. We can switch over to the ventilator of NIV CPAP. We can switch over to next mode of ventilation, that is called BiPAP. BiPAP is a mode of ventilation without doing endotracheal intubation. With this NIV mask, non-invasive mask, we can maintain the pressure difference between the inspiration and expiration, ISAP and ESAP, and we will mechanically deliver tidal volume to the patient because of the pressure gradient between the inspiration and expiration. We can switch over to NIV with a BiPAP mode of ventilation without any invasive methods. And if it is also fails, definitely we have to go for invasive ventilation with a proper Paka ventilator therapy with endotracheal tube in situ. And in those conditions, most of the patients die when the patient is intubated and connected to the ventilator in most of the situations in ICU setup. So these are all the oxygen therapy modalities that we have to maintain for this COVID-19 type 1 respiratory failure, because this brain circuit with NIV mask, the patient having very good respiratory effort, there is no problem at all. The patient having less respiratory effort with tachypnea more than 30 and the respiratory muscles going for weakness, fatigue of the respiratory muscles, we can switch out to NIV mask to the BiPAP mode of non-invasive ventilation. Okay, the one thing I want to emphasize regarding this oxygen therapy is concerned, nowadays the mucormycosis are rampant today, and more than hundreds of the patients are affected in Tamil Nadu now. And mucormycosis, we are using steroids to the patient, and most of the patients with the comorbidities, especially in diabetic patients who are all already immunocompromised, we are dumping with the steroids for COVID-19 infection, and there is every chance for spreading of this mucormycosis, because the mucor is within, not from without. And one thing that we have to emphasize this regarding this mucor is our oxygen therapy flow meter with the humidifier use the sterile water, not the tap water or the mineral water to the humidifier bottles, because most of the time these humidifier bottles are not at all changed, and the water levels are not changed, and waters are not changed because of this mucor may be the source from these water bottles. I mean, these humidifiers attached to the flow meters for oxygen therapy. Never use boiled or tap water or mineral water. That is the most important point. All should remember it. Water up to the lower marked bottom line, never it should be very full, and the water level in the humidifier should be checked daily and topped up, and the water in the humidifier to be changed very daily, and once in a week the humidifier should be washed daily with soap water regularly and rinsed with clean water and dried air before it used. And once in a week the humidifier to be soaked in the antiseptic solution for 3 hours and rinsed with clean water, because I have seen the mucors are sometimes present in the humidifier bottles. I have seen that. That is why I am emphasizing this point to all the medical fraternities and healthcare workers. Take care, have a watch, have an eye on the oxygen flow meter humidifiers. Okay, thank you, my dear fraternities, and thank you so much for your patient hearing. Thank you.